is the way to go, not only because the drugs act synergistically, but also because the reduced dose of the individual drug decreases the chances of toxicity and drug-related problems. Now, whether we use intermittent top-ups, continuous infusions, or a patient-controlled analgesia doesn't significantly alter the outcome. And oftentimes it's the institutional protocol which dictates what you end up doing. PCA does possibly reduce the overall dose, but whether that is clinically significant is doubtful. Now, I won't insult your intelligence by telling you how to put an epidural or how it works. Let's quickly look at some of the practical problems that you might encounter during the procedure. So, sometimes you have a situation where you're inserted the needle and you feel that you ought to be in the space. You're 4 or 5 centimeters inside, but you don't have a loss of resistance. Now, this might be because of a bit of tissue debris occluding the lumen of the needle or a little blood clot. So what you can do is quickly remove the LOR syringe and give a quick jab with the stilette. So that might dislodge the tissue debris and you might find that the resistance is gone. Of course, if you're unlucky, you might be greeted with a river of CSF as well. Sometimes you just can't get the space. You might be hitting bone or for whatever reason. Nothing really for me to say about that. I guess you have to reposition the patient, reorient yourself, and retry at a higher or lower interspace. And the one thing that helps, at least I find it helps, is if you're using a center hole towel in a sitting position, removing that and using a single lower sterile drape gives you a better picture of the back and a better idea of the midline. Sometimes it happens that we can't thread the catheter. Everything else was fine, but you try to push it in, it doesn't go. So this might be because of an anatomical problem. We do know that the epidural space need not be a uniform space. You might have connective tissue septa dividing it into compartments, and this might impede the movement of the catheter. Or it might be because you're not in the epidural space itself. So I think when you have a doubt, it's better to redo the procedure rather than trying to force the catheter inside. And the next problem that some people do inject saline or water, distilled water, in an effort to open out the space. But I think that's best avoided because you're already having trouble. If it doesn't work, you're going to redo the procedure and you'll hit this level and you'll find the fluid coming out. You'll wonder if it's CSF. It's messy and it's avoidable. Sometimes you have blood in the catheter on aspiration. So this might be because of the tip of the catheter being inside an epidural vein. Obviously, if that's the case, it needs to come out and be resited. But it might also be because of accumulated blood inside the epidural space, secondary to the trauma of the procedure itself. So what you can do is give a quick intrathecal shot, and maybe after an hour or so you can aspirate. If you don't get blood, it's probably safe to use. But if you get fresh blood after that time period, you need to replace it. Sometimes you have a unilateral block, and this is probably because the tip of the catheter has moved to one side. So withdrawing the catheter half to 1 centimeter, putting the patient with the painful side dependent and giving a small bolus might resolve the problem. But if it doesn't resolve the problem, I think it's good to resite the epidural at an early stage. And sometimes it happens that everything went well, but it just doesn't work. I think it's okay to give another small bolus and wait for a little longer. But if you need to redo it, you need to redo it, and it's good to do that early. And when you resite an epidural, it's always good to go for a combined spinal the second time because you've given an initial dose, 10 to 15 ml, you've given another 5 to 10 ml to try again. So siting an epidural and giving another 10 ml is pushing your luck, and I think you should just do a CSE. Regarding the test dose, I think ultimately with the test dose, what are we trying to achieve? We want to make sure that the catheter is not intravascular or intrathecal. Now, if you give, say, a 10 ml bolus of 0.125% bupivacaine, that's about 12.5 milligrams. If after giving that bolus you don't have a motor component, you don't have motor weakness, you're quite sure that you're not in the intrathecal space. And if you have good analgesia with this dose, you know you're not in the intravascular space. So a lot of people don't give a test dose, they give 2 5 ml boluses, and if the patient has good analgesia and no motor weakness, they just continue to use that. That's what I do as well. And the other reason is a patient in labor, unlike say an elective surgery, is a patient who wants immediate relief. So doing the test dose, waiting a few minutes, and in case she has a contraction, she'll have tachycardia, which interferes with your inference of the test. And then you wait for the contraction to pass, you start again. It's very uncomfortable for the patient. So I don't use a test dose, and a lot of people don't. Moving quickly on to potential complications. Hypotension can be preempted with preloading 500 ml or so of a crystalloid. And even after that, if you do have hypotension, which is rare, you can manage it with vasopressor. 5 to 6 milligram boluses of ephedrine should suffice. Pruritus is a very common problem after intrathecal opioids. And I think except for naloxone or nothing else works. So what I do is I warn the patient as I'm giving the intrathecal shot. I tell them they're going to be comfortable, but they might have itching, which lasts generally not more than 20 to 30 minutes. At least severe itching doesn't last longer than that. And once they know it and they expect it, they are okay. Rare complications, postdural puncture headache. Now, I don't know whether to call this common or rare. Obviously, it depends. The incidence depends on the experience of the practitioner. I think a mild headache, it's okay to be conservative, wait for it to go away. But if the headache is severe and debilitating, I think epidural blood patch should be considered. It works like a charm. And obviously, the patient selection is important. For example, elderly person who's had a hernia surgery might not mind lying in bed for 2 days watching cricket. But somebody who's just had a baby, she needs to take care of the baby. She wants to go home, get into a routine. Obviously, you'd like to keep her comfortable earlier. Of course, if the tip of the needle has gone intravascularly, you can have local anesthetic toxicity. If it's gone intrathecally, you can have a high or a complete spinal. And one should always keep in mind the possibility of a subdural injection whenever you have an unusual or unexpected kind of block. Neurological sequelae is quite rare. Neurological sequelae lasting longer than 3 months occurs at a frequency of 1 in 20,000 epidurals. So the numbers are reassuring, but when it happens, it can be quite devastating. And I think what we should do is to keep from injecting anything into our patient's back that is not approved for intrathecal or epidural use. Oftentimes, we hear of somebody doing something, putting in clonidine, clonidine is still okay, but neostigmine, ketamine. I think if you're feeling adventurous, there are other things you can do, bungee jumping or freed, whatever. But don't put something new into your patient's back because you're feeling adventurous. Hematoma and abscess, spinal hematoma, epidural abscesses are rare enough complications that one hopes never to encounter in our lifetime. Moving on to what I'd like to call mythical complications. First of all, does epidural prolong labor? I think per se, epidural does not prolong labor, although patients with an epidural might end up having a longer labor. But this is only because having the labor allows the obstetrician to give a longer trial, especially with second stage issues where the head doesn't rotate or the head doesn't descend adequately, where they would have resorted to a section early I think having the epidural helps a little longer. Now, is there increased intervention which includes both forceps, vacuum, and cesarean sections that is due to an epidural? I think after decades of debating, the answer is finally no. And I think there is a lot of bias over here because patients with severe pain in early labor are more likely to have a difficult labor. And it is these patients who ask for pain relief. So there is a bias there in any prospective study. Back pain, I don't want to even talk about that. We know that all our patients blame everything on the epidural, hair fall right down to the ingrown toenail. So of course back pain they would attribute to it. We know it's not true. I'd like to leave you with this image of a patient of mine. Don't worry about consent. She's my wife. I took her permission. This was about 10 minutes before my second son was born. And you can see she's quite comfortable. So, I'm not an obstetric anesthesiologist, but I have been giving a lot of epidurals, upward of 1,500 in the last 5 to 6 years. So, all of this is just practical and not theory. I'd be happy to answer any questions if there are. I think if that's what you find, you've answered your own question. I think oftentimes it's what your hospital is available at your institution that determines what you end up using. So, and I think that's very true. You'd rather have an intentional dural puncture with a 26 gauge needle than an accidental dural puncture with a 18 gauge 2E needle.
After the 0.125%, do you give in infusion or do you keep giving bolus?
I've tried both. Generally, I give intermittent top-ups of 10 ml of 0.125% bupivacaine with 20 micrograms of fentanyl. I've also tried 0.0625% of bupivacaine with 2 mics per ml of fentanyl. They both work fine. But with the continuous infusion, towards the end of labor, it might not suffice. It might not give you the S2, S3, S4 block. So you can give the patient additional boluses.
So how much?
You can give up to 10 ml of 0.125 to 0.25 even, because the requirement late in labor is more.
Manisha, I would like your comment on this. What is your practice for?
What we found is that we have been using patient-controlled epidurals like a PCA, and we've been using it for more than 10 years now. And there is plenty of evidence to show that apart from lower drug use, which is not that significant, it does give a lot more patient satisfaction.
What drug do you use? What concentration? What additives? And how do you bolus it?
We are using 0.1% bupivacaine with fentanyl 2 micrograms per mil. And we actually do recommend a test dose. What we use the same mixture for test dose. We put in 10 mils and wait for 3-4 minutes. And what I tend to do is that as soon as your epidural is in, before you've actually fixed it, you put your test dose in. So by the time you've fixed it, it will be 3-4 minutes, and the midwife will be checking the blood pressure every minute. So you will know whether or not it's intrathecal. And then you give another 10 mils of the same mixture, and then set up the PCEA pump. 20 total, yes. To start it off. 0.1%.
So 0.1% means you're giving very small dose.
Yeah. This is the mixture which is used for walking epidurals as well. It's exactly the same thing, although I've yet to meet a patient who actually wants to walk in labor.
Okay.
Whenever the patient asks for it.
It's all patient request.
Once they are in established labor,
Yeah.
you don't want to put in too early, but once they are in established labor, like he said, once they are committed to labor, once they are either in established labor or the obstetricians have decided that they're going to induce her today and not letting her go home.
Good.
We're not doing
No,
that.
I think that is not a good practice at all.
How many days
actually-
are you going to leave it then?
Yeah, you should not leave any device which you're not going to use when it is required.
Right.
If the patient actually needs to go to cesarean, you don't actually for some reason, well, you can use it, but you do not know it's working or not. It's no point actually just putting the device and leaving. I think it's not a good practice to follow. Guru, you have I think last question.
The
Sorry.
other thing I wanted to say, yes, you can ask.
That is true. Yeah. Yeah.
Yeah.
Yeah.
Right.
That's right. Yeah.
That's,
The other thing I was going to say was we've actually now got clear transparent drapes, which makes it easier to
Easy.
identify the midline for when
Yeah.
you struggle to put an epidural in,
Yeah.
and that often helps.
Yeah, good. Yeah, okay. Next session. Sorry, we'll start with the next session. I think epidurals and spinals all usual stuff. A lot of discussions go on. Yeah. Guru doesn't agree because I don't do as many. But we come to something else now. You actually have patients who hasn't had epidural or spinal but actually going for a cesarean section. It could be elective cesarean or could be a emergency cesarean section. How do you provide analgesia for these patients? Okay, without actually requiring too much of post-op opioids. And Surjit is going to talk to you about a very low-tech technique. Anybody can do it. There's no reason why patients should actually be in pain after the operation. Okay, you may not have pethidine, you may not have morphine, you may not have any kind of thing, but with just simple, just a needle and a syringe of local anesthetic. Surjit, thank you.
Good morning to all of you. Now we are moving from UK metros to very small town. That is my town. And at the very outset, I'm very much thankful to Sip sir for choosing me for talking on LOR tab block. This is my small town, and this is famous for historic monuments. And if sometimes I go for Takon, and maybe you may visit this place of Assam. This is a lot of historic monuments are there. So greetings to all from my small town. How many of us use ultrasonography for epidural location? Maybe answer is very, very few, isn't it? Still, we are relying on our old trusted technique, that is the epidural needle, LOR technique, as well as our hand, the tactile sensation. But if you have this ultrasonography, that is well and good. I am not against about ultrasonography, but the lecture is for those who do not have access to the ultrasonography. There are a lot of issues why it is not accessible. It is not my not under the talk. But who have no ultrasonography, but they want to give quality care to the mother, probably this LOR tab block may be the answer. And if you know the regional anesthesia anatomy, you see this abdomen, there are three muscles, external oblique, internal oblique, and transversus abdominis. Our idea is to put the local anesthetic here, in between the transversus abdominis and internal oblique muscle. Okay? Because this spinal anterior MI, they will traverses there, and before supplying the anterior abdominal wall, they will traverses in between the internal oblique and transversus abdominal muscle. our idea is to locate this tab plan. You have to got the external oblique fossa click, then internal oblique fossa click, then deposit the local anesthetic here. That is the tab block, what we are going to describe. Now, before going to the tab block, you have to remember that it will give myocutaneous analgesia. First and foremost thing, myocutaneous. It will not provide visceral analgesia. For visceral pain, you have to supplement with diclofenac or paracetamol. Number one. Number two, it will consistently cover from T10 to L1. Some studies are there demonstrating that it can go up to T6. And there is also discussion by Guru sir, that is tab block, and you can do the HRA, that is hemi replacement arthroplasty. But forget about these issues. Remember, but still there is studies there. But forget about this, that tab block will provide analgesia from T10 to L1. Means any infrabuccal surgery, you can go to the tab block. Third issue is that if you cross the incision, the midline, you have to give the bilateral block. Okay? Like in the financial incision in cesarean section. Means in the cesarean section, you have to give bilateral tab block. These are the three main issues before going to the tab block proper. Now, any LR block, the first and foremost thing is the needle. Needle should be blunt and it should be short bevel. Okay? Now, you can use toy needle. You can use 21 gauge hypodermic needle. You can modify it for the tab block. That is LR needle. You can use stigmoplex needle, or you can use that is Whittaker spinal needle. So we will mainly concentrate on epidural needle location of tab and Whittaker spinal needle location of tab plan. Now, how to make a needle blunt? There is a good discussion and video in our group. You can go through that by Sip sir. So I will not go detail about it. You can modify any needle to blunt. Now, in 2001, Rafi et al. And he described a triangle that is called triangle of Petit. This is the triangle of Petit. And he told, if you locate the triangle of Petit, and if you go for the 2-pop and deposit the local anesthetic, block will work. But later on, it was found that it was not so easy to locate and palpate this triangle, especially in the obese person, as well as the pregnant lady with a lot of fats and saggy skin. It is very difficult to locate this triangle of Petit. Now, in our talk and in our discussion, forget about this triangle of Petit. In our technique, we do not search for triangle of Petit. Okay? It was described in 2001, but till now, this LOR tab block is not popular amongst anesthesiologists. Why? What is the reason? We found there is a constant failures are there in this LOR tab block. And we found that if you search for the triangle of Petit, if you have not obliterated the cushion effect, then you deposit the local anesthetic in wrong plane, or you are using the inadequate volume. That's all leads to the constant failure, and this is very frustrating to anesthesiologists, and they are not doing LOR tab block. Now, what is the cushion effect? And this is diagram again from Sip sir. If you look at this diagram, this is the skin, this is the subcu fat, this is the external oblique fossa, internal oblique muscle, and this is the fossa, internal oblique fossa, and this is the tenbracilis fossa. Now, this subcu fat, that will act as a cushion like this. Okay? Now, because these LOR needles are blunt, so it requires considerable amount of the force to pierce the skin. You have to give pressure to pierce the skin. So, to do so, this process, it will take the skin, subcu fat, and external oblique fossa in the same plane. When you will give a pressure, the needle will suddenly come out and needle lies somewhere here. That is in the internal oblique muscle. Means we are bypassing an important track in our LOR tab block. That is the external oblique fossa. So we are not getting the pop, as well as we are not meticulously looking for the external oblique fossa, and needle lies somewhere here, internal oblique muscle. And you go further, then you will get the fast pop. That is a pop of internal oblique fossa. But your mind is saying, oh, I have to give the 2 pop. Then you need to go further, and it will traverses the transversalis fossa. You will get the pop of transversalis fossa. And you think that I got the 2 pops, my needle is in the proper plane, now I will deposit the local anesthetics. Means you are depositing local anesthetics not here, it is the plan. This is the plan, but you are depositing local anesthetic in the below the transversalis fossa and sometimes in the peritoneum. And because if you think that I got the 2 pops, I have deposited local anesthetic in the proper plane, you will be happy, my block will work. But when you go check the patient in 4 to 6 hours, the block actually did not work. And that is very, very frustrating to the anesthesiologist, and he give up this LOR tab block. But reason is this all things, there is a cushion effect. So how to obliterate this cushion effect? You can use a nick in the knee, in the skin, like in the epidural, in the lumbar epidural. You can withdraw the needle up to the skin after initial puncture, come out and go again search for the pop. Or you can go to the needle through needle technique. Now what is the needle through needle technique? Again this diagram from Sipsar. Now the needle through needle technique, the Whittaker needle, there comes as an introducer, sharp introducer. Okay? Now this sharp introducer, just you put the introducer just below the skin at the subcutaneous fat. This is the cushion that we have described. Now you are obliterating the cushion effect. Then introduce the Whittaker needle. You look for the bounce over the external oblique fossa, then pop. Again bounce over the internal oblique fossa, then pop. Means your needle is now in the proper planes. Means you are meticulously looking the external oblique fossa pop, bounce, and internal oblique fossa and pop. So means your needle is in the proper plane and block will definitely work. And this is how we obliterate the cushion effect. Now this is very interesting article. In 2012, and they in the BJA they told that we should not do LOR tab block. What they have done, that they have studied in 36 adult patients and they asked the anesthetists who are doing the LOR tab block, and they have gone real-time imaging, ultrasonography, because they have fancy gadgets. Then they found that only 23.6% was in the correct plane. Only 23.6%, remember. And there is a 18% there is a peritoneal puncture, and they have stopped the study because there is a lot of peritoneal puncture. But we challenge this study because they have not mentioned in their literature how they have obliterated the cushion effect, which is important in any LOR tab block. They have not mentioned it. How they have eliminated, they have also did not mention a bit about it. And they have not meticulously describing the 2 pops, bounce pops, they have not mentioned. And they have not also mentioned about the free black flow of local anesthetics. Mind it, if the needle is in the peritoneum, there should not be any black flow of local anesthetics. But if it's in the plan, there is back flow of local anesthetics. So they have not mentioned. So our addition findings are, the weight is more than their claims. So it cannot be said that the LOR tab block should be stopped. Now whether it is scientifically proved, let's see some video of LOR tab block. This is the costal margin, this is the iliac crest, this is the introducer. You go just below skin, see, obliterating the cushion effect. Then you go for look for the bounce over the external oblique fossa, then pop, again bounce, pop. This is the second pop. Then again you look for the backflow of local anesthetic here. See, it is like needle is in the CSF. It is not in the peritoneum. Again pop. In another patient this is. Again pop. Again dye injection. This is pop. Bounce again. And you will get the second pop. Is it? Now I will give the dye injection. You see, this is after first pop of external oblique fossa, I have given the few ml of dye, and this is after internal oblique fossa pop, I have given few ml of dye. And see the spread. It is going after 5 ml of local anesthetics. It is going caudal and cranial direction. So it is not in the peritoneum. It is in the plan. So this is again by the epidural needle. You see. Say it is going. Yeah, this is the first pop. Again you will get a resistance. You will get the second LOR. So you can use the epidural needle also for location of tab. And so in this patient, the patient asked for the this absolute analgesia. So I have given bilateral catheter in this patient. So you can use this minimal resources like epidural needle or Whittaker needle for tap location. No need of fancy gadgets. Now, complication of this technique, in our from 2010-11, I have not found this type of complication like peritoneal puncture, visceral injury, LA toxicity. These are very, very rare possibilities if you are looking this bounce and the pop meticulously. And this is one vial that is coming very today, nowadays. So initially I have used this is 0.25% of bupivacaine, later on shift to the levobupivacaine, but nowadays this whole vial contains, there is 50 ml, that is 0.2%, there is 100 milligram. That is very easy to adjust according to the body weight of the patient. So you can use 0.4 to 0.5 ml per kg in each side, but never cost 2 milligram per kg. So this needle to needle technique, this technique is not only felt, but this bounce and the pop can be appreciated from the distance. So there is no such previous description in literature of visual endpoint technique in LOR tab block. Complications are almost nil. It can be considered as a learning curve for beginners. And whether you can go to the mastery of this technique, yes, you can. You get familiar with this cushion effect, go through it, get experience in all infraumbilical surgeries, practice, and if you spend a lot of time there, you will get master on this technique. So this is one of your study. This is I'm going on in my hospital. That is from the 2011 till now. So I have taken 200 numbers of the patient, all 60 kg elective patient. And the spinal anesthesia was given with 25 gauge Whittaker needle with bupivacaine 10 milligram plus fentanyl 20 microgram, followed by tab block 0.25% bupivacaine bilaterally 20 ml, and they are supplemented diclofenac 12 hourly intramuscular. Our aim was to use the primary outcome was to the VAS score and toileting. What we have found that 93% of the patient has VAS score of less than or equal to 2 in post-op period. 2% has severe pain, and 5% asks for the rescue analgesics. Now, if you consider a VAS score in 48 hours period, you see at rest 0, 0, 0, then 1, again 2, and 1 at 46 hours. And if you at the moment you see 0, 1, 1, 2, again 1. So it is almost, that is 1 to 2 in first 48 hours period. And if you see, 91% of the patient has said it is easy toileting at 8 hours. 5% has some discomfort, and 4% has no toileting at all for other reason. And also, do not forget about the after pains, especially in the multi-patient. Multi-patient, there has this losses the tonicity of the uterus, and because of the some clot, patient may have after pain, and also you have to look about this after pain, and we have get discussion in 2013 in our Facebook group anesthetics. Now, advantages of this technique is it is a very low cost technique. It gives an early mobility. It increases the bonding between mother and baby because the mother is very pain free and she is very much comfortable to give feeding to the baby. It is easy to master. It has an improved success rate, and it is a pleasant hospital stay for mother. To conclude, it is a very simple technique. It is a low cost. It is a cost of the LA only. It gives effective post-op analgesia up to 48 hours. Safe where epidurals are big no. If the patient has got this emergency cesarean section, coagulation failure, like that where you cannot put the spinal or epidural, maybe this patient is under general anesthetics, the tab block may be an option. And no need of ultrasound, only need is the training and only practice. No need of training, only need is the practice. This gives a superior quality of analgesia even in a real setup like ours. And lack of resources are not an obstacle for a quality care. Always remember, the expert in anything once a beginner. So today you start, tomorrow you will be expert in this technique. So thanks for Tassian for kind listening. Yeah, sir. Chetan, sir. Yeah.
There is one article in July-August issue of Regional Anesthesia and Pain Medicine. They have raised a red flag alert on tab blocks in cesarean sections. Have you read it? I haven't had access to the article. Has somebody read the article?
This is what we were discussing yesterday. Okay, what is coming out in research is not always true. Okay, you're looking at a very small. And that's why if we actually start collecting now data of tap blocks being done by loss of resistance technique from India, we would actually exceed any literature. I mean, there are people like
there are people
Dr.
and there
Prema is there,
yeah,
okay?
absolutely.
I mean, she started using it. We can actually,
These
this will go into, not into 10,000s, it'll go into 100,000 cases. And these have been done very, very safely with very good effect. And that's because we have taught them how to do it properly. Now that article, I actually wrote a response because I have in 2011, the article where this images have been taken, I wrote an article. It's a free access article. In Hindavi, you can actually access the loss of resistance nerve blocks. Okay. And I wrote a reply to that letter. They didn't even, they refused to actually accept that even as a correspondence. Because they know that there's no training for loss of resistance. Nobody trains them how to do that. And everybody goes and tries to attempt them without realizing what a cushion effect is. We have actually, before that, almost, I think it was in 2010, we actually published a new technique for the ilioinguinal block using the needle through needle technique in anesthesia. And that's where we started doing I think Surjit presented that work in Aura 2 months back, which won an award. We talked about in the anesthetics. So you can do it if you know what is the cushion effect. Dr.
Yeah.
Prema. Yeah.
I have done more than 200 cases. I must thank the forum that I really learnt it from Dr. Shiv and Dr. Surajesh. I've been doing for all the cases so much that just before I came from my place, I had a cesarean section. I was in a hurry to travel. My obstetrician says, "Where are you going? Give a tab block and go." Others are not doing.
Okay, I'll give 5 seconds, I'll do it.
Yeah, it's fantastic. And my experience
just
is
one
that
minute.
at the beginning, we had a lot of resistance. What you're putting in fact, even my husband commented your aseptic technique, all that. I said, you're opening your abdomen. And we can't put a symbol. I argued. We had a quarrel. I had a quarrel with my husband, who's a surgeon. So we have to do it carefully. And in these 200, 250 patients, touch wood, I haven't got any complications till now.
Yeah.
Only the first few cases, I was little hesitant,
Yeah.
and I didn't blunt the needle properly.
That's
So
it.
it's only the technique of blunting. I must thank Guru, I think. He was the one who showed me on the video. He said, put a cup, invert a cup and blunt. Who said that? You said that. Yeah. So that technique really works, and I'm very happy about it now.
And
We have
just
got actually,
one
we
thing
got
about
that video.
blunting.
It was
Yeah.
it was the bowl. It was the bowl because it comes in the sterile set. This
Yeah.
is as close to the sterile technique you can get.
Yeah.
The
So
other thing-
you invert the bowl containing betadine,
Yeah.
tap it twice, that's done. Simple.
The one thing about blunting, you shouldn't do it too much because then you just make 2 taps and that's enough actually, just to take the edge. No, just one thing, Shiv, about the tap blocks. A lot of stuff coming in literature now that it's actually the absorption of the local anesthetic and its systemic effect which is causing the analgesia
yeah.
rather than the nerve block itself.
I made the
So
same comment.
Pardon?
I'd made the same comment to him,
No, because, after having read that, every time I put a tap block, I keep asking myself, is it my tap which is working or is it because nowadays a lot of studies on intravenous lignocaine are also there for analgesia. So just your views on this.
Yeah, the tap blocks, okay, I think the culprit is ultrasound guided tap blocks. Okay, even in the expert hands. Okay, I mean, I have done this month, November, one of my studies has got a randomized control trial studies that got published in renal transplant patients. And I can tell you, having done lots of these tap blocks, you even in expert hand, you see some of our videos, you can actually see that you actually end up injecting some amount into the muscle. Okay, you inject local anesthetic in the muscle, where is it going to go? Into the blood? It's an IM injection. And I can assure you, there are thousands of people actually, they're done by trainees. They think they're doing a beautiful block. Okay. No, actually half of the local anesthetic is injected into the muscle before it actually gets into the plane. It happens with me, having done thousands of them. It happens with everyone. And you start actually saying that you are perfect. I can tell you the loss of resistance block is actually far, far superior to ultrasound block. And that's a chap who uses ultrasound every day. Okay. And that's only possible if you actually learn how to use the blunt. Okay, we'll show you the video, which is actually there. I think it is Okay, this is the link to the article if you want to know the theory behind that. Okay. This is called the loss resistance article. Okay, it's free of access. Anybody can download it, PDF, or you can save it to it. Okay, this is showing how to actually blunt a needle. Okay. So you take an ampule. Okay, any ampule which is actually available to anyone, your sterile ampule, saline ampule, anything. Okay, all you need to do is actually you take it and scratch it inside. Okay. You don't have to take a video, Pallavi. You can actually get the whole video to yourself. Okay. You see that how it is. Okay. You need to do that. Okay. That is the tip. That is the bevel is actually facing inwards. Okay. So you do it. What you end up doing is actually you do a parrot beaking of the tip. Okay. There's another technique which we use is actually you take a bigger needle and you take a needle inside the needle and you can actually use as okay, you see that? You go inside the needle, and then you just actually start curving the tip. So you can actually control how much you can. Unlike in the scratch, here you can actually control how much you can do that. Okay. So these are very, very simple techniques. Now, how much do you think a hypodermic needle costs? Okay, yeah. So even if you don't actually want to use a spinal needle, which is costly, all you need is 2 needles or maybe an ampule of saline and a 20, that's it. The only problem is that you may not actually get enough length from a green needle. Okay, so if you use a spinal needle, that gives a good length. So that's what, you see, that was a beautiful demonstration which Surjit has given. That was in quite a few patients you've seen. That's number. How nicely you can visualize. That is seen. I will tell you, when I used to do the technicians used to say, oh, 1 pop. They're telling me, okay, I'm doing it. There's 1 pop, 2nd pop. Yeah. Now, leave alone a personal experience of anesthetist. One of my colleagues actually had a surgery done, and it was an emergency, and they didn't know what they'll find. He ended up actually a Hartmann's procedure. He didn't have any pain relief. He requested for a tap block. So I did, and I actually did. He was in the hospital for quite a few days, and I gave him at least 6 sessions going to the hospital and doing it. I used to do it with the needle-through-needle technique. And he used to tell me, he says, oh, 1 pop, 2 pop. Within seconds, he used to have pain relief. As I was injecting, he said, I can feel it. So you can use it for post-op analgesia. You can actually go to the ward and do it. So it is a low-tech technique. I think there might be a lot of, you try to send an article to BJNL, they will not accept it. Okay, you know that this is not high-tech. You send an article or ultrasound, everybody, oh, give it to us. Okay, everybody's after high-tech things. This is low-tech, anybody can do it, a needle and a syringe.
Just one comment on personal experience. After Shiv brought up this needle through needle, I thought, okay, let me try. And I had an ultrasound, so what I did was used to do this and then put the ultrasound. And 9 out of 10 times it was between external oblique and in the external oblique fascia, as Surajit showed earlier.
Yeah.
Not the cushion effect. It was not the cushion effect. It was actually the scarpa fascia, because you do get a pop in the abdominal fascia itself, even before you enter. So what I do now is hold the whole thickness of the abdomen.
Yeah.
You can feel, you can measure, and I don't look for pop until that depth is transferred.
Yeah. You don't get that. See, if you are doing it with without a needle through needle technique or using a nick and things, all those things, that is what this cushion effect is about. Whether you actually are using cushion or you actually withdrawing. Same thing holds true for fascial block. Fascial block fail for the same reason.
Scarpa fascia.
Absolutely. Yeah, you don't have to go through that. Yeah.
I'm always, criticizing tap block. Yeah. Most of the time, what I could find out that there is something called tap block hyperalgesia. Where it comes from? Yeah. Basically, as you said, the muscle one which gets stretched up. Yeah. The part of the drug which goes to the muscle, that causes pain, and especially it happens with very thin abdomen and younger. They complain of literally one hernia
Yeah.
or appendix, I forgot. She cried and
Yeah.
cried, and it was a fantastic spread. But the spread came after some time, after
Yeah.
getting into the muscles up and down.
Yeah, that's why I say you end up injecting local anesthetic into the muscle.
That is
Yeah.
that's what ultrasound guided.
Yeah.
But it happens, and
Yes.
they get some pain.
Yeah.
But later on, when the stretching effect, it might have got benefited.
Yeah,
But
you're lucky. You guys are lucky because you're doing in awake patients. We guys cannot give blocks in hours. We give anesthetized patient. So you can imagine how many patients must be getting it. Now we don't see it for the reason that you are creating pain before you take away pain.
Yeah.
Yeah. So that is the disadvantage of doing them awake. You give them pain before you actually have. There is no surgical pain.
No, tab block most of the time we do asleep.
Yeah.
This is not the block we do
Okay.
awake.
Okay.
This was also asleep.
Okay.
But it came post-op after extubation. Suddenly, with all those multimodals, he started crying.
Yeah.
Yeah. It was a perfect spread.
Yeah.
But later part of the story.
Exactly. You say you actually struggle before you're in the right plane. But you have injected already local anesthetic.
Yeah, that's true.
By the time you realize you actually given half the syringe of local.
You don't have control.
Yeah, exactly.
You might end up injecting in wrong plane sometimes.
But also I feel that many a times because the visceral pain is not taken away, even in bariatric surgery, there was a lot of, they used to talk a lot about just tab block being sufficient. But there are some patients, who just have such severe visceral pain for whatever reason, I don't know if it's surgical but there are some patients who will have. So maybe in your patient, could it have been visceral pain or some other pain?
It was
rather
appendix
than the
side.
myocutaneous pain?
Possible.
Yeah, guys, I think we are getting late and we are running half an hour. Yeah. No, we can actually discuss. No, we can discuss this later on. We have discussed a lot of things on the net. That's it. You got advantage of that. We got 10 minutes for tea. Also, you can actually discuss. We'll be all outside. You can discuss with us outside. Thank you. Thanks very much, Manisha and Purnima.
Sorry. Yeah. Please have instead of pop here, pop the hot pakoras outside, please. They are waiting for you before they get cold. Yeah. Thanks.